Assisting cricothyrotomy. When endotracheal intubation or tracheostomy cannot occur quickly and other non-surgical methods have failed to establish an airway, an emergency cricothyrotomy may be necessary. This procedure involves puncturing the trachea through the cricothyroid membrane. The nurse's usual role in this procedure is to assist the physician or other specially trained practitioner responsible for airway management. The practitioner ideally performs a cricothyrotomy using sterile technique. However, use of this technique may not be possible in an emergency. Equipment. For all types of cricothyrotomy, gloves, PPE, face mask, eye protection, gowns, antiseptic solution, sterile 4x4 gauze pads, sterile drape, sterile towels, tape, oxygen source, O2 delivery equipment, vital signs monitoring equipment, pulse oximeter and probe, end-tidal carbon dioxide detector, stethoscope, disinfectant pad, optional, sterile gloves, 1% lidocaine syringe needle. For scalpel cricothyrotomy, scalpel, number 6 or smaller tracheostomy tube, through-shoe dilator, tracheal hook, handheld resuscitation bag or T-tube, and wide-bore O2 tubing. For needle cricothyrotomy, gauge 14 through the needle or over the needle catheter, 10 ml of syringe, IV extension tubing, hand-operated release valve or pressure-regulating adjustment valve. Commercially prepared cricothyrotomy kits are available and may be used if available at your facility. Preparation of equipment. Have one person stay with the patient while another collects the necessary equipment. Inspect all equipment and supplies. If a product is expired, is defective, or has compromised integrity, remove it from patient use. Label it as expired or defective, and report the expiration or defect as directed by your facility. Prepare a sterile field with a sterile drape. Pour antiseptic solution onto gauze pads. Open sterile packages and prepare to hand and practitioner supplies as needed. Implementation. Gather and prepare the necessary equipment and supplies. If possible, confirm that informed consent has been obtained and that the signed consent form is in the patient's medical record. Perform hand hygiene. Confirm the patient's identity using at least 2 patient identifiers. Explain the procedure to the patient and family if appropriate, according to their individual communication and learning needs, to increase their understanding, allay their fears, and enhance cooperation as time permits. Raise the bed to waist level before providing care to prevent caregiver back strain. Perform hand hygiene. Put on gloves and as needed, other PPE to comply with standard precautions. Assess the patient's rate and depth of respirations, accessory muscle use, chest wall motion, and breath sounds to identify inadequate respiratory effort. Apply a pulse oximeter and EtCO2 detector. Monitor oxygen saturation and end-tidal CO2 levels to identify respiratory effort. Position the patient supine with the neck in a neutral position to keep the cervical spine stabilized. Administer supplemental O2 before and throughout the procedure using the most effective delivery route: blow-by, nasal cannula, face mask, handheld resuscitation bag, or T-tube. The practitioner puts on PPE and, if available time permits, sterile gloves. The practitioner cleans the patient's neck with antiseptic cleaning solution according to the manufacturer's instructions and allows it to dry. Assist as needed. Assist with draping the patient's neck with sterile towels. The practitioner locates the precise insertion site by sliding thumb and fingers down to the thyroid gland. The practitioner locates the outer borders by noting the location where the space between the fingers and thumb widens. The practitioner assesses for hematomas which may displace the trachea to the unaffected side. The practitioner then moves fingers across the center of the gland over the anterior edge of the cricoid ring. Assist with the practitioner in anesthetizing the area with 1% lidocaine as directed and as time allows. Using a scalpel. Hand the practitioner a scalpel. The practitioner uses the scalpel to make a horizontal incision of less than 1/2 inch or 1.3 centimeter long in the cricothyroid membrane just above the cricoid ring. The practitioner inserts a dilator to prevent tissue from closing around the incision. If the dilator isn't available, the practitioner inserts the hand of the scalpel and rotates it 90 degrees. The practitioner inserts a tracheal hook into the opening, allowing for passage of an appropriately sized cuff tracheostomy tube. If a small tracheostomy tube, number 6 or smaller, is available, the practitioner inserts it into the opening and secures it to help maintain a patent airway. If a tracheostomy tube isn't available, the practitioner may tape the dilator or scalpel handle in place until a tracheostomy tube is available. If the patient can breathe spontaneously, attach a humidified oxygen source to the tracheostomy tube with a T-tube. If the patient cannot breathe spontaneously, attach a handheld resuscitation bag. Trace the tubing from the patient to its point of origin to make sure you're attaching it to the proper port. Inflate the cuff of the tracheostomy tube with a syringe to provide positive pressure ventilation. Auscultate bilaterally for breath sounds and check the patient's end-tidal CO2 level to confirm tube placement. Obtain the patient's vital signs. Anticipate a chest X-ray to evaluate tube placement. Discard used supplies in appropriate receptacles. Discard your gloves and other PPE in appropriate receptacles. Perform hand hygiene. Using a needle, attach a 10 ml syringe to a gauge 14 through the needle or over the needle catheter. Hand the catheter to the practitioner, who inserts the catheter into the cricothyroid membrane just above the cricoid ring. The practitioner directs the catheter downward at a 45-degree angle to the trachea to avoid damaging the vocal cords. The practitioner maintains negative pressure by pulling back the syringe plunger while advancing the catheter. When the catheter reaches the trachea, when air enters the syringe, the practitioner advances it and removes the needle and syringe. Tape the catheter in place. Attach the catheter tube to one end of the IV extension tubing. Attach the other end to a hand-operated release valve or a pressure-regulating adjustment valve. Connect the entire assembly to an O2 source. Trace the tubing from the patient to its point of origin to make sure that you're connecting it to the proper port. Press the release valve to introduce oxygen into the trachea and inflate the lungs. When you can see that they're inflated, release the valve to allow passive exhalation. Adjust the pressure-regulating valve to the minimum pressure needed for adequate lung inflation. Auscultate bilaterally for breath sounds and check the patient's end-tidal CO2 level to confirm tube placement. Obtain the patient's vital signs. Anticipate a chest X-ray to evaluate tube placement. Discard used supplies in appropriate receptacles. Discard your gloves and other PPE in appropriate receptacles. Perform hand hygiene. Completing the procedure. Monitor the patient's heart rate, blood pressure, respiratory rate, and O2 saturation level throughout the procedure. Check for bleeding at the insertion site, subcutaneous emphysema, or inadequate ventilation, which might indicate tube displacement or an air leak, and tracheal or vocal cord damage. Return the bed to the lowest position to prevent falls and maintain patient safety. Perform hand hygiene. Clean and disinfect your stethoscope using a disinfectant pad. Perform hand hygiene. Document the procedure. Special considerations. Pediatric alert. Scalpel cricothyrotomy isn't recommended for children younger than age 12 because it can damage the cricoid cartilage, the only circumferential support to the upper trachea. An ultrasound machine may be used to visualize the patient's anatomy before starting the procedure. If time allows and your facility indicates that cricothyrotomy falls within universal protocol guidelines, follow the necessary steps, including conducting a timeout immediately before starting the procedure to ensure that you have identified the correct patient, site positioning procedure, and as that all relevant information and necessary equipment are available. The Joint Commission issued a sentinel event alert related to managing risk during transition to new International Organization for Standardization tubing standards that were designed to prevent dangerous tubing misconnections which can lead to serious patient injury and death. During the transition, be sure to trace each tubing and catheter from the patient to its point of origin before connecting or reconnecting any device or infusion at any care transition. And as part of the handoff process, route tubes and catheters having different purposes and different standardized directions. When the patient has different access sites or several bags hanging, label tubing at the distal and proximal ends. Use tubing and equipment only as intended and store medications for different delivery routes in separate locations. Complications. Complications include failure to obtain the airway and damage to the structures, including laceration of the thyroid cartilage, cricoid cartilage, or tracheal rings. Other complications include false passage of the tube into an extratracheal location, tracheostomy, infection, and subglottic stenosis. Documentation. Document the date and time of the procedure, circumstances necessitating the procedure, assessment findings, and the patient's vital signs before, during, and after the procedure. Document the size and type of tube the practitioner inserted and the centimeter mark of the skin opening. Document confirmation of proper tube placement, X-ray findings, and tidal CO2 level and auscultation findings. Note whether spontaneous respirations occurred after the procedure. Record how much oxygen was administered and by what method. Note any procedures the practitioner performed, such as endotracheal intubation, after establishing the airway. Document any difficulties that occurred during the procedure, prescribe treatment, and the patient's response to the treatment. Also, document any medications you administered and the patient's response. Document teaching provided to the patient and family, their understanding of that teaching, and in any need for follow-up teaching.